Today I'll be talking about peptic ulcer disease. So it is very important to know what cells of the what cells of the stomach secrete what type of hormones. So there are mucus cells which secrete alkaline mucus to protect the stomach lining from acid gastric juice. Cheap cells secrete pepsinogen, which is activated to pepsin by the HCl in the stomach, pepsin itself via positive feedback mechanism. Parietal cells secrete HCl, which helps convert pepsinogen to pepsin and kills microbes in the food. Parietal cell also secretes a very important element known as intrinsic factor, which helps in the absorption of vitamin B12. G cells or endocrine cells secrete several hormones and substances like gastrin, histamine, endorphins, serotonin, CCK, and somatostatin. A few points of H. pylori, which is Helicobacter pylori. It's a gram-negative bacillus. It is a spiral rod. It has a unipolar flagella, right? It is microaerophilic. It is urease positive. Urease positive is the most important character of the H. pylori bacillus. Factors responsible predisposing for peptic ulcer diseases: poor socioeconomic status, poor sanitation, domestic crowding, exposure to gastric contents of infected individual, more common in developing countries. Now coming to chronic gastritis, it inhibits parietal cells, which causes decrease in the production of hydrochloric acid. There is further cell injury, which is caused by CAG-PAI, which increases cytokine production and repression of tumor suppression gene. Due to increased level of cytokines and interleukins, there is increasing in mucosal and systemic humoral response. So peptic ulcers are areas of degeneration and necrosis of the gastric intestinal mucosa exposed to acid peptic secretion. Though they can occur at any level, the most common areas are either duodenum, most common is the first part, or stomach along the lesser curvature and antrum. So coming to the important causes of peptic ulcer disease, first one being H. pylori infection, NSAIDs, stress-induced, smoking, drugs other than NSAIDs, and Zollinger-Ellison syndrome. Now coming to how the peptic ulcer exactly occurs, coming to in a normal case scenario, what are the damaging and what are the defensive forces? The damaging forces is gastric acidity and peptic enzymes. The defensive forces include surface mucus secretion like bicarbonate secretion into mucus, mucosal blood flow, apical surface membrane transport, epithelial regenerative capacity, and elaboration of prostaglandins. Coming to C, in case of increased or damaged or impaired defenses include ischemia, shock, delayed gastric emptying, and host factors. Injury include increased damage will be due to H. pylori infection, NSAIDs, aspirin, cigarette smoking, alcohol consumption, gastric hyperacidity, and duodenal gastric reflux. So this is the necrotic debris. This is non-specific acute inflammation and granulation tissue, and ultimately ending up in fibrosis. Now coming to the sites of peptic ulcer disease, most common is duodenum, that is first part along the anterior wall. Stomach, usually the antrum or along the gastric curvature. In the stomach, it is along the lesser curvature because the action of gastric juice is maximum in this area. Gastroesophageal junction in the settings of GERD within the margins of gastrojejunostomy. In duodenum, stomach, or jejunum in patients with Zollinger-Ellison syndrome, within or adjacent to Meckel's diverticulum containing ectopic gastric tissue. Along one thing you need to remember is if the ulcer is along the posterior wall, it leads to severe bleeding due to rupture of the gastroduodenal artery. Type 1 occurs in gastric body, type 2 occurs in the antrum, type 3 occurs within 3 cm of pylorus, usually accompanied by duodenal ulcer, and type 4 is found in cardia. Coming to the gastric ulcers, gastric ulcer may be benign or malignant. Benign may be found distal to the junction between antrum and secretory mucosa associated with antral gastritis. Malignant ulcers, which are usually found in the antrum and more than 3 cm in size, tend to develop malignancy. The investigation of choice for diagnosis treatment of peptic ulcer is endoscopy. It is used for both diagnostic as well as therapeutic for bleeding ulcers. Now coming to the drugs that have been used for treatment of peptic ulcer disease are H2 receptor antagonist like cimetidine, ranitidine, famotidine and nizatidine. Most properly used are PPIs like omeprazole, lansoprazole, rabeprazole, pantoprazole, esmoprazole. Mucosal protective agents are sucralfate, prostaglandin analog, bismuth containing compounds. Antacids like Mylanta and Tums are also used. 2 H. pylori regimens are available. One is pre-pack, that is lansoprazole, clarithromycin and amoxicillin taken BD for a duration of 14 days. And Helidac, it contains bismuth, tetracycline and metronidazole taken 4 times a day with PPI or H2 blockers for a duration of 14 days. So the 2 H. pylori regimens are pre-pack regimen. One is pre-pack, PREPAC, which consists of lansoprazole, clarithromycin and amox, and Helidac regimen, which contains bismuth, tetracycline and metronidazole along with PPIs and H2 blockers for a period of 14 days. The first line therapy triple regimen is recommended for 14 days followed by 4 to 6 weeks of PPIs or H2 blockers. So for 14 days you will give triple regimen followed by you will continue those PPIs or H2 blockers for a period of 4 to 6 weeks. For successful therapy, laboratory diagnosis should be done after 4 weeks of antibiotic therapy and after 2 weeks of PPI or H2 blocker therapy. Most commonly used are stool antigen test or urea breath test and biopsy based test. So first line therapy consists of triple regimen. You will give it for 14 days followed by 4 to 6 weeks of PPI or H2 blockers. The second line therapy includes levoflox based therapy. Levofloxacin and amoxicillin and PPI is given for 10 days followed by furazolidine therapy. Furazolidine, amox and PPI given for 14 days. When a patient comes to you with indication of H. pylori treatment, he should be tested for H. pylori. If it is negative, rule out. If he is positive, first line treatment should be started. Now when you should wait before changing the treatment or for having further investigations, you have to wait for at least 1 month after treatment finishes. No antibiotics, bismuth compounds or PPIs inhibitors in the meantime. Then you do a urea breath test or a stool antigen test. If positive, after second line treatment, third line treatment with endoscopy with H. pylori culture, treat according to the antibiotic sensitivities. If urea breath test is positive, then start the second line treatment. Refer to a specialist or consider whether treatment if it is still indicated if positive after third line of treatment. If it's negative, H. pylori will be ruled out.